This week on the BackTable podcast. I'm really looking to see how we use technology to enable us to kind of find that sweet spot, but also how our guidelines evolve and all of that.
Yeah, no, I think it's a challenge, especially on the standardization versus individual style. You're right. You don't want to be robotic. You kind of want to be yourself. And people respond to that genuineness. I mean, in our interviews, they highlight genuineness, trustworthiness, honesty, open. Like these are traits that people really like in their communication. And, it's really also interesting in that patients really value confidence in their surgeon. And they really appreciate people who are very knowledgeable. So like these are all ingredients. And, you don't want to take away things that make you who you are as a physician.
Hi, everyone. Welcome to BackTable Urology. My name is Ruchika Talwar, and I'm a urologist in Nashville, Tennessee. Today, I'm thrilled to be joined by Dr. Ray Tan, who's an associate professor of urology at UNC Chapel Hill. Dr. Tan and I will be having some interesting discussion around decision-making when we're considering surgical management versus surveillance or conservative management for GU cancers. Dr. Tan, Ray, thanks for being here. Why don't you tell the audience a little bit about yourself?
Thanks, Ruchi. It's a great honor to be here. I'm a big fan of BackTable. So right now I'm at UNC. I'm the division chief for urologic oncology in the Department of Urology. I also have a research program focused on decision-making and risk communication, as well as increasingly a survivorship component, and take care of patients with urologic cancers. So that's got a little bit of everything going on.
Yeah. And, like you, I'm also a urologic oncologist. And it's interesting. I find that some of the most difficult conversations in my clinic are not necessarily the patients with the highest risk cancer or the most complex surgical decision-making in terms of needing a major operation. Sometimes the most challenging conversations tend to be those where we're considering maybe doing surgery versus not doing surgery. And I know you have done a ton of work in this area, so that's why I was really excited to record this conversation. But why don't you first start with sharing a bit about your journey? How did you start getting interested in decision science and urologic oncology?
Yeah, no, I think in many ways it's a bit circuitous and serendipitous, how I kind of ended up here. Definitely, during the course of my training was very fortunate to be trained by wonderful surgeon scientists over at the University of Michigan. And they really got me thinking about how do we provide better care. I mean, I think I tried, a bunch of different things, comparative effectiveness research, aging-based research. But what really was, motivated me at the end of the day was trying to figure out how we can provide information to surgeons to really help their decision making. I think what I've sort of discovered over the course of the first few years of trying to do research and trying to make changes is that you can find something that's really interesting, but sometimes translating that to an actual practice change is really challenging. And so that's where I really got interested in more of the decision-making process and decision science specifically. And then I was starting out very much on the surgeon-facing side. And one thing that I constantly encountered, especially when I started at UNC, was what about the patient? Obviously with communication, decision-making, there's two parties in there. And so I would get this question repeatedly. And those questions, plus just being exposed to people like, Chris Eigel and Mark Litwin and Ethan Bash and Angie Smith, like you sort of figure out, okay, well, to really try to solve this puzzle, you kind of have to attack it from both angles.
Yeah. So important. I mean, that the patient perspective in counseling and patient-physician communication, I think, to your point, is often not necessarily the first place where our mind jumps when we think about how to optimize our discussions and improve our conversations. But that really is like central to this whole concept. Some of the work that you've done has been centered on this idea of decisional conflict. And so I just wanted to take a moment to ask you, what exactly is decisional conflict in this context? How common is it, and why is it a problem?
Well, there's a formal definition for decisional conflict. I mean, I think, briefly, it's the sort of degree or state of uncertainty about what's the best course of action to take. It's from the patient perspective. And it's really kind of been a standard bearer of evaluating the decision-making process in sort of medical decision-making, the field. And so you see it throughout, whether it's evaluating a decision aid, looking at the current state of decision making. And so it provides like a through line to understand what patients are going through in decision making. I think it serves as a pretty good proxy for downstream satisfaction with the decision, regret about the decision, and even health outcomes. And so I think that's a really good starting point. There's some validated instruments that we use so we can know that what we're measuring is what we're trying to measure. And I think that is often the starting place when we're trying to figure out how is the decision making for whatever disease that we're looking at.
And specifically for urologic oncology, this really, I think, becomes front and center when you're having conversations for renal masses and for prostate cancer. And, just for our audience background, the reason I say that is often small renal masses less than 3 centimeters, we can safely surveil. And there's been a whole body of evidence demonstrating that. We've talked about that on this podcast before. So I don't want to talk so much about the clinical side of that. Similarly, for prostate cancer, we can often surveil patients with low-risk prostate cancer. And again, from a clinical lens, we've unpacked that. But I want to talk a little bit about the work that you've done recently, looking at this idea of basically what influences the patient's decision to either go on surveillance for, I know, you have some work in this space for renal masses. So let's start there. What are some studies you've done? What's some evidence that you're aware of, specifically in this space?
Yeah, no, I think that's a great place to start. I 100% agree. Shared decision making, active surveillance, the challenge of deciding between treatment versus active surveillance. Really, there's 2 great models that exist in your urology. It's really localized low-risk prostate cancer, maybe increasingly starting to get into favorable risk.
Yeah.
And then small renal masses, right? So these are like the real 2 big entities that we face on, a day-to-day basis that really can pose a dilemma for patients. And it's really interesting because I think when you come from it from the clinician side, you think of it as the disease severity. I think we would all agree that these are very favorable, very treatable, manageable diseases. So the pressure and then sort of the pressure on us is actually pretty low. Mm-hmm. Like this patient's going to kind of do well no matter what we decide. And what's really hard to keep in mind, especially as our understanding of the disease has evolved, is that that's not necessarily what the patient comes in to that conversation. And so we've been doing a lot of work. It started with our study grade SRM, which, was collecting a lot of information about decisional conflict for these patients as they were coming in live during sort of their new diagnosis. And we followed that up with another study that's been doing qualitative interviews to really understand the decision-making experience and understand the communication that feeds into that. And it really has been very eye-opening. I think the other part that's been really cool for us at UNC and our study team is that we've brought on patients onto the study team. We have a survivor who gives us a lot of concrete feedback during our research meetings. And we have a stakeholder panel too that we've been bouncing around different ideas and different results to get initial reactions. So it's been really eye-opening in many ways. I think one thing is that, for small renal mass specifically, patients come in and they come into the clinic with a belief that, and a worry that this is cancer and this is a cancer that can be life-threatening to them. Mm-hmm. And so the biggest challenge I think that we have to face, and I think the biggest driver often of like some of the decisional conflict, is how do we go from that starting point and then have a conversation that talks about not only surgery, but after surveillance. That's a bit of a leap.
Yeah. So I want to talk more about that and what we can do as clinicians to help set ourselves up for success in those conversations where a patient may have a preconceived notion about needing an operation and not really need one. But first, I want to hear more about your study. I know that some of these studies are in process. You might not have all of the findings fully published yet, but what have you learned through the process of these investigations?
Yeah, so I'll tell you about a few things that we have going on. So I mentioned the first study, GRADE, which is Genomic Risk Assessment and Decisional Evaluation for Small Renal Masses. It's a study that kind of was, like I said, it was somewhat just fell into our laps a little bit. We had, as part of an initiative from our cancer center here at UNC, they wanted to try to take genomic biomarkers to the next step. And so we, put together this protocol to start collecting more tissue from biopsies and from specimens for small renal masses to try to figure out if there's a way that we can, better risk stratify. And as part of that study, to really enrich it, we collected a bunch of PROs, which is where we got all these surveys about decisional conflict and personality traits, decision-making traits and stuff. And that whole study is designed around an idea of evaluating what the experience is like for patients who are newly diagnosed with T1 renal masses and how it may differ depending on whether you get a biopsy or not. And so that is really the crux of that study. I think that one of the first things that we found, this is a paper that was out in sort of Journal of Urology, was looking at just the state of decisional conflict for patients with small renal masses. I think we know in prostate cancer, right? It's been pretty well documented that there's a lot of decisional conflict that patients experience. And it's very easy to understand why. They have different treatments, and these treatments have like real potential side effects for people, right? So that is a very difficult sort of situation. For small renal masses, there's much less that's been studied. Some colleagues of mine at UCLA really were the first to look at decisional conflict, Joe Shirk, Aaron Laviana, Chris Seigel, and they, found that patients generally had a relatively low decisional conflict for small renal masses. I think what was interesting is when we looked at it, we found that, on average, patients generally didn't have as much decisional conflict. But when you look at it over various time points in that first month or two, about half of patients do experience an elevated level. So at some point, they are experiencing difficulty with the situation. I think one thing that was really interesting too is that on average, about a quarter of patients actually have more decisional conflict. So once they make an initial sort of preliminary decision, their worry and their uncertainty about what they made in terms of decision actually worsens. And I think that's something that's really interesting. We found a bunch of different factors too that would influence the amount of uncertainty patients have with their decision making. There's a bunch of things that are related to the clinical factors like age, health. These make sense, right? These are raised or put into question whether you're going to benefit much from treatment. And so that becomes harder for people to process. But we also found a bunch of factors related to the patient and their ability to understand information that really sort of feeds into decisional conflict. And then we, looked at more specific, or have been looking at more specifically, the role of renal mass biopsy and communication specifically into that interplay.
So tell me about age. What specifically did you find?
So, things like if you had the older you got, the more decisional conflict that you had. When you had more complex masses, the more decisional conflict that you had. And if you had a cystic mass, the more decisional conflict that you had. And I mean, these all would make sense because they would all suggest that the benefit of doing treatment really becomes less clear. And so you get more in that gray area of risk versus benefits between something like surgery versus something like active surveillance.
And what about when you're deciding between treatments? So let's say you've decided that you want to do something, but you might have two options on the table. And what I mean by that is maybe you could do a partial nephrectomy, or maybe you could do cryoablation for the renal mass. Is that something you've explored, or do you think some of these findings would be able to translate over into that scenario as well?
Yeah, I mean, I think, what's interesting about small renal masses and, in talking to patients about their decision-making experience, I think one thing that we have found based on the interviews we've done is that the divide between surveillance and treatment is a lot greater than between different treatments. I think people can get on board with doing surgery, a partial nephrectomy, or doing ablation, or potentially, SBRT, as so long as the mass is getting treated. I think it's a more of a gap.
Yeah.
To get them on board with active surveillance if that's considered to be the better option for them.
Yeah, that makes sense to me. And I think to your earlier point, it's a little different than in prostate cancer, where even when you've decided to pursue treatment, the treatments have significant quality of life side effects. So for example, in both scenarios, we're often counseling patients on erectile dysfunction, but perhaps the stress urinary incontinence conversation goes a little differently, or perhaps the addition of needing a testosterone blocker would go differently. So it makes sense to me, what you're saying, and why maybe in prostate cancer, the decisional conflict sits in like a different space. But I'm wondering, from all that you've learned in your research, let's talk a little bit about how you've adapted your practice to maybe structure the surveillance conversation differently. Tell me a little bit about how you approach it and maybe how that approach is influenced by the work that you've done in this space.
Yeah, sure. I mean, I think, it's great in that when you're doing research in something that you see, you get to try different things to see how it resonates with people. I think one thing that was really eye-opening in terms of the research and how it kind of has informed how I personally approach it in clinic is really just seeing how much what you say and do can play a role into how people perceive the situation. And so we kind of got an idea about that with like our first study looking at drivers of decisional conflict. I mentioned it, but patient-centered communication, the degree to which like the patient is perceiving that the information and communication they're receiving from the physician is really supportive and helping with their decision making is more than just providing like the nuts and bolts information. Is about empathy and support and coping and building rapport. Like when that was high, decisional conflict really, really went down. Mm-hmm. And then when we looked at renal mass biopsy and where a renal mass biopsy really potentially made a difference. Like overall in that study, that paper is going to come out soon actually, but we find that on average, renal mass biopsy may not have as much of an impact on reducing decisional conflict, but it can in patients whose communication wasn't particularly good or who have difficulty processing information. So we can really have sort of started to see in our research that communication, how you frame the choice, really, really has an impact on what patients are thinking, feeling, and ultimately what they decide. I think in hearing from our patients and our patient stakeholders and everything that have been involved with this study, what's really, really interesting is they come in, I mentioned this before, they come in scared. Mm-hmm. Worried. Part of the survey, we actually asked people about their worry, about their perceived risk of metastasis and everything for a T1 renal mass. For a T1 renal mass, right? Especially for a small renal mass, that risk is like less than 3% of like metastasis, right? Mm-hmm. We know from Phil Perazio's research that this is really, really, really safe. But when you ask patients what they think the risk of it spreading for them is, like the average was like 45%.
Wow.
Like they felt like it was almost a coin toss that this little mass would spread. And so I think the first thing that we learn is like, how can we just turn down the temperature on the conversation so that we can even have the conversation about what your options are? Mm-hmm. So I think that was one really big key thing that we took away. And so a lot of our subsequent research has been really focused on like, how can we potentially do that?
Yeah. And what do you think? What's the best approach? I mean, when I think about my own clinic, I do try to give patients numbers because I think that helps alleviate some of the guesswork and that coin toss that they may be perceiving in their head is the potential risk of, for example, metastasis. I often will give them numbers of here, depending on the size of the mass, using Perazio's data or other, the DISAR registry or other large data sets that we have out there. I know Rob Uzo's done a lot of work in this space too. I try to say, here's the risk. Here's the percent chance that this could be benign versus malignant. And even if it is malignant, here's what we know the average growth rate is and how quickly it grows and all of that. So I guess I approach this thinking about numbers, but you're the expert. So I'm curious, have you found that to be effective? Are numbers helpful? What are patients like? What can help actually turn down that temperature?
Yeah, no, I think absolutely data is really powerful. And I think it's really helpful for people to hear that information. I think there's two things that I would keep in mind, when relying on, the numbers. I think one, there seems to be, for some reason, and it's true for everybody, right? There's like the numbers that you have in the study and then the numbers that you feel that is your own personal risk. And so someone can understand like, hey, yeah, I understand what you're saying is that my risk is like 1%, 2%, but I feel my risk is higher.
Yeah. Yeah. Great
And
point.
so how do you, deal with that? I mean, that's like something that, definitely comes up often in conversations. And then also when you're providing a number, it can be interpreted in different ways. So if you're trying to say like, hey, you know what, you have like a 99% chance of surviving this cancer, so good news, like you have nothing to worry about. Like some patients may sort of interpret that as being dismissive
Yeah.
and disrespectful.
Great
And
point.
then you can't even have that conversation really now. So
Yeah.
it's really, really nuanced and delicate actually to even have that initial sort of jump point. I think, one thing that we've heard from our patients and something that we are trying to work on in terms of messaging is how can you sort of acknowledge like what they're feeling and, what they're worried about. And I think if you can acknowledge that first and you can do it in a warm way, then that can allow you to bring in some of more of the facts of the science. And I think they become more receptive to it.
Yeah, totally. Like that really resonates with me because I always think about the patients, and you may be going from a, let's say, 20-centimeter renal mass with IVC thrombus, like you're in that room, and then your next room is someone with a 9-millimeter renal lesion, questionable, like we don't even know what it is. For that, in your mind, it's like, oh, this feels less heavy. But let's not forget, for that patient, that might be the first time they've ever heard the word cancer. They may have lost family members to cancer. And so I try to like remind myself of that when I'm going in the room and I say, oh, this is definitely safe to surveil. I think it's so true that you acknowledge, like, I'm really sorry that you're going through this and that you're facing this diagnosis. I know it can be worrisome. So like things like that, I think are great. And I love that you call that out. Beyond just language and like some of this, I'd say the soft skills of communication, because that's what some of it is, right? Like feeling the room, understanding how the patient's responding to the way you're counseling them and like fine tuning. But beyond that, are there some tools or like visual decision aids that are helpful? Are there like resources that you use or give to patients?
Yeah, no, absolutely. I mean, I think there in small renal mass, in prostate cancer, there's no shortage of different tools. There's like P3P. There's like, that's like a pretty well established one. Chris Seigel and his group, developed one too. There's a bunch of different tools. For small renal masses, the selection is a little bit less. Music has like a guide. It's a little bit more sort of provider facing, but still could be used. There's a decision aid that was developed out of Canada. That's a pretty good one. There are a couple more that are under development. I think what can be really helpful as just like a simple tool though for patients, and sort of going back to the idea of like turning down the temperature on the conversation, is just like showing them the imaging and showing them the picture of the mass. That's something that in our interviews that patients have identified as something that they really appreciated.
Mm-hmm.
I think there is it's like the information that tells you that this is not really something that is as aggressive as like, a different type of cancer, but there are different things that you can do to make them feel that it's not as aggressive or as worrisome. And so when they see a picture, when you show them something that is as small as like a 2-centimeter renal mass, which is like about the size of a grape, right?
Mm-hmm.
Like, I mean, I'm sure we've all done partial nephrectomies and like I looked at it at the end, or like, oh, that was really small.
Yeah.
And then, when people see that, then I think they start to feel what you have been trying to tell them. And so I think that's a really, really simple visual aid for doing it. And it's actually quite surprising because, where we're at, we see a lot of people who've been, seen someone before. And then I ask them, oh, has anyone ever showed you what your mass looks like? And most of the time they'll say no. And so I think that's a really good, simple tool that's available to everybody to do.
Yeah, yeah. I have that same experience. I'll ask them, have you seen this yet? And then they love, and I'll always say, here's your normal kidney. Let's start with that one. And then here's the kidney in question, and here's that area. And I can see it on their face immediately, like, oh, yeah, that does look really small. The rest of my kidney looks fine. So I think that's a great tool. What about any web content that's out there? Like, for example, sometimes I'll tell my patients to go on a patient advocacy website because I find that often hearing it from other patients who have face these same decisions could be helpful. I know in bladder cancer, we have Beacon. In kidney cancer, I'll often tell them about Kidney Can, that organization. But I'm curious if you found any online resources that you really like and recommend.
Yeah, I mean, I think there's some great patient support groups out there. Casey Cure is good. KCA is another one. There is, I think it's IKCS. They have like a decision aid also, but it's quite lengthy. But it goes into all the nuts and bolts. So for someone who's like high literacy, really needs a lot of information, I think it's a great resource. We haven't talked about it, but all the LLMs, ChatGPT, they're like all the rage right now.
Yeah.
And they do, it's all about prompt engineering. Like if you put in a good prompt, you get really good information. I think what's really interesting now, and relates to our research, is just like over time when you like sort of play around with it, you see that it's becoming much more empathetic. Like there's been some effort into making it, more like compassionate in the tone of what information they're relaying. What I would say is that I think there's a lot of opportunity though to really try to make some better online material, especially for small renal masses, and that's something that we're hopefully working on.
Yeah. Well, you mentioned it, and it was on my list for later, but let's dive into it right now. I was going to ask you about, in the era of AI, I think in the way I think about AI in medicine, it's like it's an adjunct. It's a helpful tool, and we got to figure out, we're still learning, but we got to figure out how to use the tool effectively. But first, I guess, what's been your experience? Like, have patients said, because I've experienced this, patients come in and they say, well, this is what ChatGPT told me. What's been your experience? Do you think that's a good thing? How can we approach those conversations when patients come in, like a little less Dr. Google, now it's like Dr. AI? What are your thoughts?
Yeah, no, I think in many ways that like what I've seen in practice is that people are coming in, and it's a variation upon a theme that we've all had that experience with. Like it's been many years where people have been coming in with like printouts from like Google or something like that. And now just ChatGPT is the new printout, the new information source. And so I think in many ways, the way that patients are using it is not that different than how they've been accessing information, medical information, via the internet in the past. I think what's really interesting is that, and this is something that we've heard in our qualitative research, is that when patients get this diagnosis, they often get this, they get this, in their primary care office, they get it in the ER, a lot of renal masses are instantly detected, right? They start to get information. It may not be the right information. People, just because they think it's cancer, just assume that it has to come out.
Mm-hmm.
And what we hear is that from patients is that when they are given different information by their physician, and if they have trust in that physician, that can override so much. And so I think at the end of the day, as much as we're making progress with LLMs and everything, there's like that human component. And I'm not sure like to what degree ChatGPT and everything is going to be able to replace that. Now, my wife tells me I'm like a ChatGPT skeptic. Maybe I'm just like overly optimistic that we will have a place in the future. But I do think there is like this element of like reassurance, trust that you can really, really convey in a face-to-face conversation. That's a little bit more difficult when you're doing it, via computer or your phone. That said, I do think all these technological advances do give us an opportunity to really start kind of right-sizing expectations from the get-go.
Mm-hmm.
There's, patients, like they'll tell us in their interviews and on our panels that they went to the ER, they got like a 2-centimeter renal mass, they got the news from the ER doctor, they didn't really have any time to get to dive into the diagnosis. They, might say or might be told like, hey, yeah, it's probably cancer, you probably need to get that taken out.
Yeah.
And then from then on, that is the anchoring point for them.
Yeah.
So you can definitely imagine in a world where you have, chat boxes and, LLMs and decision aids that are there that can really sort of give him the better information at, the first time point. And then you can have much more productive conversations down the road.
Yeah, I totally agree. I think the one thing about ChatGPT, we know that it's not perfect. We know that the evidence is not perfect. often there's issues with hallucinations. But in general, it might be a bit more standardized than typing something into Google and clicking on different, like you have 10 different or 20 or 100 actually different link options, and it all depends, like the information you're going to get depends on what link you click. And so maybe there's an opportunity to get rid of some of that disinformation through using sources like ChatGPT. But another thing that comes to mind, especially when I hear you talk about this human touch and this human connection, is really the role for tools. Like I know David Keynes has done a lot of work in Well Prepped and like creating these sources of the patient hearing about their diagnosis from you before they even come to your clinic. And so this feels like a good example of a use case, I should say, a good use case for something like that.
Oh yeah, no, I mean, we have a study right now that we actually are just rolling it out. So from all the input that we've gotten from our patients and from all these surveys and stuff, we developed strategies that we feel are ways that you can try to provide a little bit more support and address some of these issues and concerns for patients in the messaging that you are providing about small renal masses. So, we kind of talked about, some of them, people who come in with a lot of worry. There's people, other things that we have found are people come in with preconceived notions that they're going to need chemotherapy because a lot of cancers need chemotherapy. We found that people want different degrees of information. People feel maybe less prepared to make a big decision about what they want to do for their small renal mass. And some people, want to know about what the potential outcomes are. And some people really want to know what the process is. They have like different framings of what information they want and how that will kind of comfort them. And so, we've been working on this adapted system of providing different messaging based on like what a person may be sort of predisposed to. And we have a study right now where we're pilot testing essentially like, do patients like the personalized message, or would they rather just kind of have like the nuts and bolts type information? But, I think that is where there is a lot of opportunity, especially with like new technologies. So like AI, AI both has the potential to identify more of these different axes of action and is probably more poised to actually develop strategies to act upon it. Like, we had to go kind of the old fashioned way through qualitative and quantitative data to find these nodes. And then when you find them, you have to make the messages. And, that took like a year, to do it for 5. AI, I think, has a lot of potential to do it more quickly, but we'll see. And we're testing that idea out right now and seeing if patients are responsive to it.
Yeah. We covered a lot of different strategies that urologists and physicians more broadly can adopt to try to help guide some of these conversations. But is there anything we haven't covered yet that you think is important to share with the audience?
No, I think we talked about, dialing down the temperature. I think that's a really, really important one. I think we've already talked about like the soft skills, sort of the building rapport and everything that can be really helpful as patients make their decisions. I do think, it's worth saying, I came up and trained during this area where, we were still doing prostatectomies on, low volume GG1 prostate cancer. And then we had, all this controversy with the PSA screening guidelines and all the downstream problems that's caused. I think, this is really, sort of a call to action to be on the forefront as a field to like figure out how can we really, lead in helping patients navigate that treatment versus conservative management. As I've said before, what we say has such big bearing on what a patient feels and what they decide. And that's a lot of responsibility. And, to borrow the, Spider-Man quote, with great power comes great responsibility, right? So I think we have a lot that we can offer into really improving how we support patients in these decisions.
Yeah. And what do you think in terms of research? I mean, you mentioned that this is an area that has not been quite as actively investigated as, for example, prostate cancer. And I know your team is doing a lot and covered what's next in your area of work. But what other areas of research are really needed here?
Yeah, I think there can be a lot more work that can be done in towards of dissecting how these conversations go. There's been a bunch of studies in prostate cancer looking at the conversation. There's a lot of insights that we've gained. Some of that data is a little bit older now, back when we were doing a lot more treatment on patients with low risk disease. But, from that, we know that shared decision making. We think we do it a lot. We probably could do a better job of it. Our preferences as physicians really have an outsized influence on patients, and it draws into question how well we incorporate patient preferences into it. Tim Daskovich over at Cedars, right? He's doing a lot of really cool things, looking at conversations and what are the little things that we're doing in those conversations that might, potentially help get a patient onto active surveillance or might, potentially get them on the treatment. And I think more work in that space is really, really needed. I think then taking that and then figuring out, okay, are there hacks or there's frameworks that we can develop for these conversations to make sure that we're doing them well and we're doing them efficiently? Everyone's busy. Everyone has a lot of patients they're trying to see in a day, right? And so I think that's really another area that's really an opportunity for us to do some work in.
Yeah. And I really think that we're at sort of the crossroads between the notion that we need to standardize and reduce variation, while also remembering that every patient is individual and has different goals and has different priorities. And so I'm really looking to see how we use technology to enable us to kind of find that sweet spot, but also how our guidelines evolve and all of that.
Yeah, no, I think it's a challenge, especially on the standardization versus individual style. You're right. It's hard you don't want to be robotic. You kind of want to be yourself, and people respond to that genuineness. In our interviews, they highlight, genuineness, trustworthiness, honesty, open. These are traits that people really like in their communication. And, it's really also interesting in that patients really value confidence in their surgeon, and they really appreciate people who are very knowledgeable. And so these are all ingredients, and, you don't want to take away things that make you who you are as a physician. And I think that's where, frameworks are a potential way of okay, how can we let you just, be yourself, but do it in a way that is going to help patients with their decisions. And, there's been some work that's been out there. Gretchen Schwartzy out of Wisconsin, she, established the best case, worst case framework. There's another one that she developed called Better Conversations. These are kind of very simple storytelling methods about how you can potentially talk to the patients, and trying to figure out the one that's going to work best for small renal masses and early stage prostate cancer, low risk. I think that's kind of where we can do some immediate work.
Yeah. I totally agree. So as we wrap up here, what would you like the surgeon listener to do differently after hearing this episode? What are some really easy, simple things?
Yeah, I think we covered a couple of them, right? I think one, just dialing down the temperature of the conversation, right? If you can sort of acknowledge the concern and fear that they're going through off the bat, I think that'll really lend itself to a more productive conversation.
Yeah.
I do think that also showing them a picture of the mass is going to be very, very effective at, sort of achieving that endpoint. And I think once you do that, I think a lot of surgeons are already doing what they are supposed to be doing in terms of going through the different options, the risk and benefits, and the potential outcomes. And, I think, when you have the right framing, when you have the right setup, then it kind of helps with everything else.
Yeah, absolutely. I think really framing that why is critical, more important than, understanding, I think, the fact. And let me just add, a decision also doesn't need to be made today, right? That's very effective when I tell my patients, we're here today to just talk about your options. We don't need to come to a decision today. We can get a scan in 3 to 6 months, come back, see how you're feeling. And that kind of takes the pressure off. So I think that's the only thing we haven't covered yet, but helping them understand that this is a journey. Your goals today may be different from your goals in a year. And our treatment plan can change based on those goals. And then they, I think, really feel like they're an active participant in the care plan that way.
No, 100% agree. I think the strategy of trying it on for size, right? Hey, let's do short interval surveillance. We're not really going to lose anything by doing it. And you can tell me if you are having trouble sleeping at night from doing it. And I think that's a really good strategy. I think the other thing that we haven't mentioned that is, worth mentioning is sort of consistency of messaging and information, because that's one thing that, more specific to renal mass biopsies, actually, that we've heard that they just, when they hear mixed things from people in the field, it becomes very hard for them. It causes the decisional conflict, actually, because they said like, well, my doctor said this and now you're telling me this. And I think that is something that can be a great source of difficulties in making a decision. And as a surgeon, especially if you're one that is, trying to find a way to have a conversation about doing active surveillance or conservative management, that may be something that you're encountering.
Yeah.
Like, how do you sort of nuancely, maybe, offer a different opinion than what someone else, may have already told them?
Yeah. And those doctors may be the ones they have relationships with. Like, I've been in scenarios where we've talked about surveillance and a patient calls me back and says, my family doctor, who I have seen for 25 years, said I would be crazy to not have surgery. And so that can be a challenge, right? To
I know,
overcome
100%.
that. So great point. Great point. Well, listen, Ray, it's been awesome talking to you about this topic. I think we've covered so many pearls of wisdom that our audience can apply in their day-to-day conversations. And this work is like equally as important as the new fancy technique, because so much of what we do as surgeons is knowing when to operate, but also maybe when not to operate. So thanks for taking the time to chat with us.
Yeah, Ruchi, no, it was an absolute pleasure.
Awesome. And to our audience, thanks so much for tuning in. We'll see you next time. Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening, and see you next week.